Hello, my name is Stuart Kimball. I'm a long-way athletic training student and I will be presenting on athletic pubalgia, or AP. AP, which is also known as a sports hernia, is a hernia that is located within the groin or abdominal area, which is indicated in the picture to the right that has a circle labeled sports hernia in that general area. The anatomy involved is the musculature to include the rectus abdominis, the adductor muscles, as well as the uh, pertaining fascia and aponeurosis of those musculature. Causes. The cause is the force that is produced on these structures that is produced by cutting, pivoting, fast acceleration, deceleration, which creates micro tears due to the stress that is placed on the fascia and aponeurosis listed before. Some signs and symptoms include deep or lower abdominal pain, groin pain that is present with activity and stops when activity stops, and then a symptom that is pertinent to males is testicular pain. Some clinical indicators include sports with the forces mentioned before, pain that onsets with activity and stops after the conclusion of activity, and then vasosalva maneuvers such as coughing and sneezing that reproduce the symptoms. Epidemiology. There's an increased chance of AP for the sports that include the forces listed before, such as soccer, ice hockey, American football, basketball, cricket, rugby, and it is more pertinent in males. AP accounts for 6% of all reported injuries, and in a study of 189 individuals with groin pain, 50% were clinically diagnosed with AP correctly. The evaluation. First, an evaluation should begin with history to include trying to find out those clinical indicators mentioned before, and then you should move on to a physical assessment. Palpation, there's going to be pain or report of tenderness of palpation over the pubic ramus, the proximal adductor region, and or the insertion site of the rectus abdominis, which is primarily located by the red circle on the graphic to the right. For range of motion manual muscle test, there's going to be pain with resistive hip adduction, and sit-ups will reproduce the pain. As far as manual muscle tests, there will be a decreased score, potentially 4 out of 5 or lower, with a adductor muscle group and trunk flexion. As right now, there are no special tests that are able to be performed to test for AP, and then for technology, there should be X-ray ordered so that you may rule out bony injury, and then MRI should be used to diagnose muscular lesions or other surrounding soft tissue injuries that may be pertinent. There is no reported specificity or sensitivity. Surgical interventions. One thing to know is that surgery is indicated for one of two reasons. I'm going to jump ahead for a second, and that is one, that non-surgical interventions have failed, or that two, the individual requires a surgery right away for whatever reasons that may be. For non-surgical, the main idea is going to be for soft tissue and joint immobilization in the general area at first, and then stretching and strengthening of the surrounding areas. The 4-week outline that was listed inside the textbook is week 1. You're going to focus on stretching the hip flexors, adductors, rotators, hamstrings, and low back muscles. This does come after the immobilization period. And then week 2 is going to be strengthening of the abdomen, hip adductors, and hip flexors. The week 3 and 4 is going to be comprised of strengthening and stretching, and then to include the tolerance of running and kicking exercises as well as jumping that is tolerated by the patient. And then for surgery is broken into several different sections. There is laparoscopic repair, and then open surgery, and then there's going to be the way the hernia is corrected, as far as reducing the hernia and then fixing the site in which the structure ruptured or is injured. And that can either be done by mesh, surgical mesh, which is in the picture to the right, or it can be done with sutures or partial repair. One thing to note is the return to play time, and then there's 100% return to play For laparoscopic and mesh repair, there's an 84% for return to play for open surgeries with minimal repair, and then 99% of return to play for open surgery with mesh. There is currently no noted changes in the surgery or leaders in the world for AP repairs. And here are my references.